This week on the BackTable podcast.
This is the first non-platinum containing regimen that is able to beat cisplatin for patients with muscle-invasive bladder cancer. So very impressive. And those hazard ratios are like 0.53 for event-free survival, 0.65 for overall survival. Very, very impressive numbers. And then we looked at the pathologic complete response rate as well. And in this group, similar to the KEYNOTE-905 study, those numbers were 56% and 64% of the patients who actually underwent surgery. Because some patients didn't undergo surgery, 64% of the patients who actually underwent surgery had no evidence of cancer at that time. So very impressive numbers.
Hello, everybody. My name is Jun Gong, and I'm a medical oncologist at Cedars-Sinai Medical Center. Thank you for joining us for this BackTable Tumor Board podcast episode. It's my absolute pleasure to introduce our guest today, Dr. Tyler Stewart, who is a GU medical oncologist, an associate professor of clinical medicine at the UC San Diego Health Moores Cancer Center, and an expert in GU oncology with a focus in bladder cancer and ctDNA. Welcome to the podcast, Dr. Stewart.
June, thanks so much for having me. Super excited to do this with you today.
We're coming hot off of the exciting GU ASCO 2026. Happy to cover some studies with you, some of which you were a discussant of these breakthrough studies. And I thought we'd begin with some practice-changing studies in the muscle-invasive bladder cancer space, starting with the KEYNOTE-905 EV303 update. Would you be able to give us a little breakdown of the study design and key findings for this study?
I'd be happy to. First off, it's a super exciting time in bladder cancer. You know, you really do see that in bladder cancer that there are just so many things that are changing, and we're making such great gains for patients. I happen to see a lot of patients who have bladder cancer, who have muscle-invasive disease or advanced disease, and it's really exciting to be able to offer better treatment options for patients. The big study at GU ASCO was actually the KEYNOTE-B15 study, but maybe we back up and we talk about the KEYNOTE-905 study, like you mentioned, and then that will bring us into the B15 study.
Absolutely.
So both of these studies are for patients who have muscle-invasive bladder cancer, and the plan for all of these patients is to undergo a cystectomy. And both of these studies are testing whether or not there is a role for neoadjuvant therapy and what that neoadjuvant therapy should be. So in the KEYNOTE-905 study, this was a study for patients who had muscle-invasive bladder cancer, and they were randomized to either receive cystectomy alone or perioperative enfortumab, vedotin, and pembrolizumab. This combination of therapy, as you well know, has revolutionized bladder cancer care in the advanced setting. We've seen significant improvements in progression-free and overall survival for patients with advanced disease, and this has really become our frontline therapy. And we're really asking the question here, should it be used in the perioperative setting? So in the KEYNOTE-905 study, this was patients who had muscle-invasive bladder cancer. Half the patients got cystectomy, and then the other half got 3 cycles of EVP prior to cystectomy, then cystectomy, and then 6 more cycles of EVP, and then the pembro, was continued up to a year. And what this study showed us was that there was a marked improvement in event-free and overall survival for patients who had the EVP and then underwent cystectomy. And what was really impressive about this study, so this study originally came out at ESMO last year and really was a practice-changing event. And it really showed us that there are patients who are cis-ineligible who should receive perioperative therapy. And what was very impressive about this is that the pathologic complete response rates here were amazing. 57% of the patients who enrolled in the study, who were enrolled in the EVP arm, had no evidence of cancer at the time of surgery. So very impressive numbers.
That's absolutely a game changer, especially with the cis-ineligible population, as you mentioned, Dr. Stewart. So pivoting right next to this, I think it makes sense to talk about the GU ASCO recent presentation of KEYNOTE-B15, which you again highlighted very elegantly as a discussant. Did you want to break down this study for us as well?
I appreciate that, June. Yeah, the KEYNOTE-B15 is a game changer. So in this study, patients were randomized to either EVP in this of a similar fashion as the KEYNOTE-905, but in this study, it was 4 cycles of EVP followed by cystectomy, and then 5 cycles of EVP afterwards, and then the pembro continued on for a year, versus GemCis. Now, we should take a step back, is that GemCis was the control arm, the comparator arm of this study. And the truth is that that's not exactly what we use nowadays. So now many of us will use combination of gemcis durva or gemcis followed by adjuvant IO therapy in high-risk populations. In the Keynote B15, there was no mandatory IO component for the comparator arms. IO was able to be given if the investigator thought, and it was allowed in the country where the patient was getting their treatment, if it was approved there, but it wasn't mandatory. And I do think that we should keep that in context because we don't have a head-to-head comparison about, for instance, the Niagara regimen, which is the gemcis durva versus EV-pembro. So the data is what the data are, but we wish the comparator had been just a little bit different, but still I think the data are pretty impressive. And what the data show here, the primary endpoint here was event-free survival, and the primary endpoint here, the data showed that there was an improvement in event-free survival and overall survival for those who received EV-pembro versus gemcis. And this is the first regimen, the non-platinum containing regimen, that is able to beat cisplatin for patients with muscle-invasive bladder cancer. So very impressive. And those hazard ratios are like 0.53 for event-free survival, 0.65 for overall survival. Very, very impressive numbers. And then we looked at the pathologic complete response rate as well. And in this group, similar to the KEYNOTE-905 study, those numbers were 56% and 64% of the patients who actually underwent surgery, because some patients didn't undergo surgery. 64% of the patients who actually underwent surgery had no evidence of cancer at that time. So very impressive numbers.
Impressive indeed. And it's great to see the dual EFS and overall survival benefit with this regimen. And it's great to see that the management, the toxicity profile, no new safety signals really expected of what we've been seeing with the EVP regimen in the metastatic setting as well. So Dr. Stewart, putting it all together, combining both KEYNOTE-905, EV303, and now KEYNOTE B15 with the superiority of EVP in both cis-ineligible and cis-eligible muscle-invasive bladder cancer, how are you going to change your practice for patients with MIBC based on these studies?
Yeah, I mean, this is the most important question. And I just want to step back and say, it is hard to compare this regimen with, for instance, the Niagara regimen. The Niagara regimen clearly showed that gemcis durva beat gemcis, and so that has changed my practice. But given the EV302 in the metastatic setting, the 905 in the cis-ineligible, and then this B15 in the cis-eligible, I think that we're seeing consistently EVP just doing a great job controlling systemic disease. And this is going to become my standard for all patients. And, you know, I treat patients at UC San Diego, and I think nearly all patients with muscle-invasive bladder cancer, when we see those patients, we're going to start them on EV-pembro. I think that we're no longer going to think about cis eligibility. I think we're just going to start with the best systemic therapy possible, and then we're going to consolidate them. Most of those patients will receive cystectomy. There are going to be some patients who decide not to have cystectomy, and we're going to have real conversations about what the best treatment options are at that point. But I think that this is really shaped how our group is doing it. I think how most GU medical oncologists are going to do it.
Agree. It's hard to argue with those powerful results here. You did mention about Niagara a couple of times in your discussion of these studies. Is there a Niagara patient that still exists out there that you would find that regimen appropriate?
Jun, that's a great question. It's hard for me to find one. You know, EVP is a generally pretty well tolerated regimen. And so most patients who come to see me, if they have muscle-invasive bladder cancer or planning on systemic therapy, I'm going to lean on EV and pembro. We do have to wait for regulatory approval, but you know, I think that that's where the field is going. It's not going to be worldwide. I think that EV-pembro in the perioperative state is going to be different for different countries. Regulatory approval for many other countries is going to lag behind. I think if gemcis durva is available and EVP isn't, I think gemcis durva is a very good regimen. For me, I'm going to have a hard time finding that specific patient. We don't know. There probably are patients we know that there are patients who don't respond well to EVP, but I don't know which patients those are right now. You know, there are some patients where they have variant histologies So if you have completely variant, pure variant histology, pure squamous, pure adeno, pure small cell, we're not going to do either one of these. We're going to do probably something else. But if you have a variant histology like plasmacytoid or micropapillary, we don't know that gemcis, durva, or EVP is better than one or the other. I think that my default is just going to be to give EVP to everybody.
No, that's a great 2 points you just laid out there, Tyler. One, the global perspective about the availability of this regimen. So that's where Niagara may still play a role. And then number two, the variant histology factor as well. So thank you for pointing those 2 points out.
Jun, I might just say one other thing. There is a small patient population that is not able to get any IO therapy. Maybe they have a severe underlying autoimmune condition that makes you very nervous. That might be a role where I would consider cisgem alone if they're cis eligible. So maybe that exists, but otherwise I think it's EVP.
Absolutely. Absolutely. Now moving on, what about the number of cycles or adjuvant cycles for EVP?
Yeah, so we don't know the answer to this. I think that I think good docs can give 3 cycles, not 4 cycles. Actually, so two questions are really within this. So one, do we need all 9 cycles? I think that's a good question. So in both studies, they got 3 or 4 cycles prior, and then they got 5 or 6 cycles afterwards. Do you need the adjuvant regimen? And the first thing that I would say to that is, I don't know if you need the adjuvant, but what we know is that we have not made great gains for muscle-invasive bladder cancer for a long time. And now we have 2 regimens that show excellent overall survival, that we are probably curing a huge number of patients. And I think any practitioner who wants to de-escalate therapy, just maybe the patient has a great pathologic complete response and they say, oh, you don't need the adjuvant EV. I am absolutely not sure of that. So maybe the patients who have the best pathologic response are the ones who are most benefiting from the EV and pembro. So if I'm giving this regimen, I'm giving the neoadjuvant and the adjuvant portion of it. And so, and I would caution clinicians who want to avoid that adjuvant EV. I mean, it's one thing if the patient has significant side effects, then we can think about dose reducing or stopping the EV. But if you want to get the same results as a trial, you got to do it the same way. And there will be other studies in the future that might tell us that we don't need that adjuvant portion, but I would still give that adjuvant portion. In terms of how many cycles prior to undergoing cystectomy, I think the decision between 3 or 4 is, I wouldn't get too caught up with that. I think that our group is probably going to do 4. If the patient's not doing so hot, maybe do 3 at that time. I think that you could be a great doc and just give the 3. You might say, well, the pathologic complete response were the same between 905 and B15. Why would I give the 4 versus 3? I'm not there. We're probably going to do 4. I'm not going to get too caught up with it.
No, but that's a great point, though. Whether it's 3 or 4 in the adjuvant setting, to really chase that impressive survival benefit here, we should try to stick to the script and give the adjuvant therapy per the trials as well.
I think that's right.
The data speaks for itself, and until there's some new data or toxicity prohibitions, I think the benefit is to give perioperative, neoadjuvant, and adjuvant therapy. With that being said, Tyler, you talked about these impressive PCR rates, nearly 50 to 60% in these studies. Do you think EVP is ready for prime time for bladder preservation trials?
Oh, I absolutely think it's ready for prime time for trials. I'm not there for doing it in practice outside the context of a clinical trial. I mean, I do think that some patients are going to get EVP and then refuse cystectomy. And I think in that situation, we have to think about what's the best consolidative therapy, chemoradiation. I think that there's going to be a question about intravesical therapy. I think some patients we might find that we can just do active surveillance. But I don't know how best to treat that. And this is something that we as clinicians are going to face all the time. I mean, I do a lot of research, but I see patients at least 3 days a week, and I'm seeing just a ton of patients with muscle-invasive bladder cancer. And many of them are asking me to try to cure their cancer and try to retain their bladder. And I have to admit, I don't know the right way to do that. And that's why we need these clinical trials. And until we have those readouts for clinical trials, it's going to be the Wild West. I mean, I think that a lot of us are going to start with EVP, and we're going to talk about consolidative therapies. And I really don't know what to do. Do we do the EVP afterwards as well if they haven't had surgery? Are we over-treating? I don't have all the right answers. I'm looking forward to the many trials that are ongoing. A couple of trials that I had noted in my talk was Matt Galsky has his study of EVP, and if you have a complete clinical response after 4 cycles or so, no definitive treatment, and those patients go on to receive some more EVP and otherwise active surveillance. And then Vadim Koshkin has a study of EVP with radiation therapy, definitive radiation therapy to the bladder. I think studies like that are going to be the future, and I'm very excited about it. I might also say that I'm a little bit nervous as well. I think that with all of this talk about bladder preservation, we're going to talk about trying to save the bladder, and then some patients are going to have recurrence in the bladder and then eventually met out. And I do think that there's a chance for patients to have recurrence if we try for bladder preservation, and they might succumb to, develop metastatic disease. We might lose our curative window. So I think that we have to be careful about this. I think that we're making gains. We want to continue to make gains and improve quality of life and save bladders. But I also think that we want to do it safely, and we want to learn as much as we can about how to do it safely. If only there were some good biomarkers to tell us whose bladders we can safely save and those that we need to take out.
Right. And that's a great segue to the next segment, and also a little bit of your alley of interest and research as well. There was 2 really key studies and biomarkers. Now moving into the biomarker section of our podcast here, the RETAIN-2 ctDNA analysis, and then there was an interesting study of the urinary ctDNA from Niagara, which really gave us some insight in both the performance in detecting bladder, local, and metastatic recurrences, as you've hinted, in things we need to watch out for. So, Tyler, could you give us an overview of these 2 studies and what key takeaways from these studies were?
Yeah, thanks, Jun. So I think that biomarkers are going to change the landscape for muscle-invasive bladder cancer, for a lot of areas of bladder cancer. I think we are learning so much about the role of circulating biomarkers and urinary biomarkers. I think the field has moved a lot towards circulating tumor DNA. I think these are great biomarkers. And we're going to talk right now about circulating tumor DNA and urinary tumor DNA. I think these are great biomarkers and they should be explored. They don't have to be DNA. They could be something else. It could be mRNA or protein-based. All we care about is biomarkers that really show us evidence of disease in the blood, and then also the best urinary biomarkers. So at GU ASCO, there were a couple of talks about ctDNA and urine tumor DNA. Pooja Gatalia from Fox Chase actually gave this great talk about the RETAIN-2 study. The RETAIN-2 study was a study for patients with muscle-invasive bladder cancer. Everybody got dose-dense MVAC plus nivolumab. They got that for 3 cycles neoadjuvantly, and then they all had a disease assessment. And if patients had a complete clinical response and had a couple of specific gene mutations that the investigators thought would mean that they have a higher chance of having a prolonged response if they are in a complete response, then patients went on to active surveillance, no definitive treatment to the bladder, no chemoradiation, no surgery, no intravesical therapy. And then if patients were not in a complete clinical response or didn't have one of those biomarkers, then they all received a definitive treatment to the bladder. And in this study, what they showed is that for patients who went on to active surveillance, a lot of those patients did really well for a long time. The interesting thing about this study as well is that they looked at circulating tumor DNA. And what they showed so clearly was that if your circulating tumor DNA was present after 3 cycles of neoadjuvant therapy, those patients were going to be in trouble. So if you still are ctDNA positive after giving a bunch of chemotherapy, those outcomes are going to be worse. But also importantly is that blood-based ctDNA markers could not predict recurrence inside the bladder for those who were on active surveillance. So patients who went onto active surveillance, even if their ctDNA tests were all negative, a lot of those patients developed local recurrence inside the bladder. And this was completely missed with ctDNA. And that really emphasized the point that ctDNA, although prognostic for patients who have muscle-invasive disease, and from the INVIGOR study, predictive of who might benefit from adjuvant IO therapy if they didn't get it in the upfront setting, it doesn't tell us anything about what's going on in the bladder. And so that study was discussed, and then the data from Niagara was shown a little bit later from the day. And the Niagara data was looking at the urine tumor DNA. So Niagara, as you recall, this is a large phase 3 study of patients with muscle-invasive bladder cancer planning to undergo cystectomy. They're all cis-eligible. They're randomized to either cisgem or cisgem-durva. And in this study, there was a event-free survival and overall survival benefit of giving the durvalumab. At GU ASCO, we saw data from urinary tumor DNA. Some of the data from circulating tumor DNA had already been presented by Tom Powell's, I think even published a little while ago, but what we saw was urine tumor DNA data. And what this showed is that actually urine tumor DNA was much better at knowing whether or not the patients still had localized disease or not. So for the patients who underwent a cystectomy, if your urine tumor DNA was negative, 75% of those patients had a pathologic complete response. So that's pretty good. Whereas if your urine tumor DNA was positive, only 18% of those patients had a complete pathologic response, suggesting that urine tumor DNA is better able to discriminate local disease versus circulating tumor DNA. And I think that these two biomarkers combined, this is going to be how we know if we have excellent both local control and systemic control of disease.
Very exciting to see both a urinary and blood-based component of ctDNA and being investigated quite heavily. So this brings an immediate question, Tyler. How are you using ctDNA in bladder cancer?
Yeah, right now clinically, I end up getting circulating tumor DNA on most patients with bladder cancer. I do it in the perioperative setting, looking at baseline ctDNA and throughout the course of their neoadjuvant and then adjuvant setting. It doesn't change my practice in the neoadjuvant setting. I think most patients who come to me to get EVP, no matter what, prior to this study, we've actually been doing GemCis or GemCis-durva, so patients should get that no matter what. In the adjuvant setting, if somebody is ctDNA positive and they have not received IO therapy, I think those patients have a very high risk of recurrence and they absolutely would benefit from adjuvant IO therapy. In this new era of EVP for everyone, I'm not so sure that ctDNA, I'm not sure how to use it just yet. I'm not going to omit EVP just because they're ctDNA negative, and I'm not going to stop the EVP if they're ctDNA negative after surgery. But we use it to follow their disease in a manner somewhat similar to just getting scans. And sometimes the ctDNA is able to better tell me if I'm really seeing disease progression, if I'm not so sure about disease progression on the scans, if the ctDNA is going up and I see something on scans which I'm concerned about, that makes me much more concerned. But right now, especially in the era of EVP, I'm not going to use circulating tumor DNA. And then urine tumor DNA, this is far behind circulating tumor DNA. I would advise nobody should use this outside of a clinical trial context yet. We don't know that patients who clear urine tumor DNA don't benefit from more treatment, or we're just not there yet.
No, and I thank you for hammering that point out. So it looks like clinical trial is the right answer, but as of right now, to guide adjuvant treatment decisions and de-escalation of treatments, not quite there with ctDNA.
I would only use ctDNA to make a treatment decision if somebody is post-surgery, never received IO therapy prior to surgery, and we're deciding whether or not to give adjuvant IO therapy. That is, right now, ctDNA positive, I'm given IO therapy. I think we've got to be careful about what we really do know about this stuff versus not. These tests are so easy to get, and we might think we know more about them than we really do.
Absolutely. Next up, we're going to move on to section 3, which is bladder preservation. And Tyler, there was 2 really interesting studies that we want to talk about. A very important negative study, in my opinion, Sunrise-2, and then the INDIBLADE study as well. Did you want to talk about these studies?
Yeah, thanks so much, Jun. So 2 really great studies, the first of which was Sunrise-2. So both of these trials are looking at bladder preservation for patients with muscle-invasive bladder cancer. Sunrise-2 took 262 patients, randomized them to either definitive chemoradiation, or the investigational arm was a combination of TAR-200 and citralumab. TAR-200, you might remember, is the intravesical device, also known as the pretzel, that releases gemcitabine. And in this, what investigators thought was, well, if the gemcitabine is going to control the disease locally, maybe get into that muscle layer, and then immunotherapy added on probably improves disease control. And what we saw here is actually that chemoradiation did a little bit better than TAR-200 plus citralumab. In June of 2024, the study was closed due to futility. And the reason was that they were not seeing significant improvements with TAR-200 plus citralumab. Here, they looked at a couple of different outcomes. One, they looked at response rate. So objective response rate in the two studies, 57% with a combination of TAR-200 and citralumab, 65% with chemoradiation. So chemoradiation looking pretty good. And then when they looked at 12-month bladder intact event-free survival, 65% for TAR-200 and citralumab, 80% for chemoradiation. So for chemoradiation, this looks like a pretty good therapy for patients with bladder cancer. I know that sometimes chemorad gets a little bit of a bad rep, but really can be quite effective, especially to gain local disease control, and something that our institution we use quite a bit. So, I think that puts TAR-200 and citralumab on the back burner for muscle-invasive disease, at least when it's used by itself. And then shortly thereafter, we also saw data for ipi-nivo and chemoradiation. So this INDIBLAZE study was also discussed, 50-patient study where they get a combination of ipi-nivo in the kind of neoadjuvant setting, and then definitive radiation with chemotherapy, and they use capecitabine here. And what they showed here was that the 2-year event-free survival, bladder intact event-free survival, was 78%. Once again, showing very good disease control with chemoradiation. It's not clear to me how much the ipi-nivo is adding to this, but probably there are some patients that significantly benefited. When you gave ipi-nivo, about a quarter of the patients had at least grade 3 IO toxicity, so it's not a nothing regimen. But I think both those studies are very nice, and they really are pushing us towards this bladder preservation.
Yeah, pretty impressive showing by chemoradiation. So where are we at, Tyler, putting all together these studies with bladder preservation?
Well, I'm super excited about bladder preservation. I might just say, I think cystectomy is fantastic. There are some patients who are suffering from issues with urination and their bladder's not functioning great and they have bad, bulky disease. I think cystectomy is great. But I think that we're going to become better able to distinguish which patients are most suited for bladder preservation. And we are having better and better systemic therapy options. And I think bladder preservation is going to be a key area of interest over the next 5 years or so, where we're learning who are the patients who are most likely to benefit from chemoradiation, what is the systemic therapy around chemoradiation, where might intravesical therapy be a role. So for patients who have chemorads, there's a high rate of non-muscle invasive bladder cancer afterwards. Can we decrease that by giving something intravesical after or with the treatment? And there are some patients who don't need any of this. So chemorads is not without its toxicity as well. Patients will get cystitis. Sometimes the bladder isn't functioning as great afterwards. Maybe there are some patients who respond so well to EVP that they don't need any definitive treatment. And we don't know how to do this right now. So this is, again, I just circle back to the same term, the Wild West. I think that this is an area where we are going to do study after study, trying to find the best regimens, the best local consolidated therapies, and try to figure out which patients really should go on to cystectomy and which can try to save a bladder.
Absolutely. Excellent points there. And moving on to our last but not least section here of this informative podcast, we're going to move on to the metastatic bladder cancer space. One study we wanted to highlight, Tyler, was an open label phase 2 study of an antibody drug conjugate, disitamab vedotin, or DV. Could you give us a breakdown of this study and key takeaways from this presentation?
Yeah, sure, Jun. Thanks so much. At ASCO, we saw a couple of studies looking at patients who have refractory metastatic disease and looking at nice studies. One actually that we're not going to talk about today was Matt Galsky's study of FX909. That's a PPAR gamma targeting agent. Super interesting new mechanism of action. We'll be excited to see where that study goes. This study was the study that you mentioned of DV. This is a global study of patients with advanced urothelial carcinoma who had already received some treatment in the past, and then they go on to receive DV. Now, DV is an antibody-drug conjugate. It targets HER2. It has an MMAE payload similar to EV. There's already in HER2 that's FDA approved in the United States. So in HER2 is a HER2 targeting antibody-drug conjugate, but has a topo-1 payload. And we've seen data that suggests that the higher the HER2 expression with IHC, more likelihood of having a good response. So this study, DV, was looking at two cohorts, kind of a cohort of HER2 high expressors and a cohort of HER2 low expressors. The high expressors were either IHC 3+ or IHC 2+ but FISH positive, and the low expressors were either 1+ or 2+ but FISH negative. And importantly for this study, patients could not have received prior HER2 targeting agents, and most importantly, could not have received agents that had an MMAE payload. So they could not have received EV prior. What this study showed, so a lot of these patients had platinum therapy or IO therapy, and what this study showed was objective response rates in both the HER2 high and the HER2 low that were very impressive, with response rates over 50%, with pretty good disease-free survival looking at, or progression-free survival, looking at about 6 months. You know, importantly, it's hard to know where we might use DV because you might think, and we don't know for sure, whether or not there is going to be cross-resistance. So in the patients who receive EV pembro and they have progression, are they going to respond to DV, which has a similar chemo payload? I'm not so sure. Tom Powell actually was doing this presentation. He showed a little bit of data of EV responses after DV, and they didn't seem to be too high. There were some responses, so it wasn't completely resistance, but the response rates weren't too high. So it's hard to know where DV falls in an era of giving EV in the frontline setting. There is a large phase 3 study of DV plus pembro versus platinum-based chemotherapy followed by maintenance of avelumab. That study is nearly fully accrued, and we're going to be excited to see those results. That might push DV to the frontline setting as a frontline therapy option. And then we're saying to ourselves, well, do I give the DV? Do I give the EV? And it'd be nice if we had a good biomarker, but we don't really have a great biomarker. That HER2 biomarker doesn't seem to distinguish too well. In the subgroup analysis, maybe the patients who are 1+ responded not quite as well as the 2+ and 3+, but they're all kind of low numbers. So I think DB is an exciting drug, but if we're giving EV pembro first, which is what I do from almost all of my patients, hard to know where DV would land.
No, it's a great breakdown and key points here about sequencing with EV pembro. Tyler, what about the other FDA-approved HER2 targeting ADC, TDXD? How are you going to sequence that, assuming DV gets integrated into?
Yeah, so we don't know about one versus the other, but I might say if they are HER2 expressing, 3+ is where the FDA approval is. In the HER2 2+, you know, the numbers look like 35% or so within HER2. So I think if they've seen EV first, I'm probably going to go with an agent that doesn't have an MMAE payload. So if this drug were to be FDA approved, which I don't know if it will, but if it were, I might think about doing something that is targeting or using a different payload. But it'd be nice to see what the data reads out. It'd be nice if we learn a little bit more about sequencing these drugs.
Absolutely. So some really great key takeaways, key insight from Dr. Tyler Stewart. It was a pleasure having you on the BackTable Tumor Board podcast, and I hope that this discussion gets distilled and we learn a lot more about bladder cancer management biomarkers. And again, I guess one takeaway is the future is really bright for the bladder cancer. We're hoping for a lot of studies to provide some more clarity. But Dr. Stewart, it was a pleasure having you. Thanks for coming on.
Jun, thanks so much for taking the time. It was a real pleasure coming on. Call me back whenever you want.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrizio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.